So this patient, Dara VD, would be a very reasonable option because of her len maintenance progression, and she does have a known history of high-risk disease. And so some practical considerations in doing Dara VD. Number one, Dara is a relatively long infusion, so it's important to be prepared for that. Things that we can do as physicians is, have the labs drawn ahead of time, perhaps the day before. We did that routinely on clinical trials. Although the good thing is we don't really need a lot of labs to dose these drugs because Dara is not significantly affected by hepatic or renal function, although the label has been only studied till clearance of 30, and similarly bortezomib physicians have a lot of experience with. But getting the labs drawn ahead of time, having the orders pre-signed so it's not a last-minute scramble, alerting the pharmacy and nursing that this is a first dose Dara, having the patient arrive early so that everybody has that benefit of time, starting the infusion in a prompt fashion with the pharmacy having mixed the drug, giving those pre-meds perhaps even at the same time that pharmacy is instructed to mix the drug, starting the drug early, not late in that day. And then infusion-related reactions are common. It's 50%, but most of the time it's grade 1, 2. And it just means that we have to hold the drug sometimes and give additional pre-meds and then re-challenge and potentially re-escalate. But all of that is only possible if you have time. And if you're practicing in a busy community practice with 9 to 5 schedule, and this patient doesn't start till 12, you're going to probably end up wasting a lot of drug, which is, and the patient won't get completed on their therapy. So another strategy that, again, has been done in studies as well now is split dose Dara. If you are a community center that's very pressed for time and you can't complete it in the first day, split it into 2 bags, 8 milligrams per kilo, day 1 and 2, and that way you have that benefit of not wasting drug should the patient have a significant reaction, and then you can do the second dose the next day. Those are very important, I think, practical considerations. It's also important to remember for those hospitals that may give Dara as an inpatient, the drug is only stable for 15 hours. So unlike other monoclonal antibodies that may be stable longer, and we can sometimes just run it very low rate overnight, this drug could potentially expire depending on when it was hung. And then 2 other practical considerations. One is the implication for blood banking. Dara's target is CD38, which is primarily on myeloma cells, but red cells also express CD38. And we know now that if you give a patient Dara and you send a type-in screen specimen to the blood bank post-Dara, it will look to them that this patient has a lot of antibodies to a lot of antigens because every red cell will be coated with Dara. So the ways to deal with that are, number one, we put in all of our chemotherapy template orders on the day 1 dosing. Please send blood bank a specimen for type-in screen and inform them that this is a pre-first dose Dara patient. And that way the blood bank is alert. And in our center, for example, they do extended testing, either phenotyping or genotyping. That way they know that when this patient comes back, even if the type-in screen is raising these weird antibody questions, they know what the patient's blood type was definitively pre-Dara. If somebody got Dara and that was not done, the other strategy is we can use enzymes to strip away the Dara from the red cell, such as DTT or trypsin. And what this does is then makes the red cell naked again without the Dara coating, and they can do their standard type-in screen. The implication of that is certain antigens like KEL will also be stripped, so the blood bank will have to give KEL negative blood as well. So blood banking is an important thing that that physicians should know about. Patients should also know about because they should have a card such that if they go to a local emergency room for perhaps trauma or motor vehicle accident, they will also be aware of what's going on. And luckily, even though this occurs, there's very little concern. We just published a paper that there's really no hemolytic reactions or transfusion reactions, so it's more of an artifact. And the biggest import of this is that it can delay transfusions in terms of finding the right product. The other practical implication of Dara, and I would broaden this to all the monoclonal antibodies, whether it's Dara, elotuzumab, the checkpoint inhibitors, all of these antibodies are typically IgG kappa antibodies. Why is that important? Well, myeloma is we test paraproteins to assess response. So now, if you're making paraproteins from the myeloma, but also giving exogenous antibody, how do you determine what is coming from what? Is it the patient or the antibody? And that can be difficult. Luckily, in community practice, it probably won't make a big difference because the main implication of these interferences is going to be significant when patients are reaching very low levels of disease where the M spike is nearly gone, and we're looking at either the difference between an M spike of 0.1 and 0.2 or 0, or immunofixation positive versus negative. At this low level of disease, it can be difficult to determine whether it's the exogenous antibody or the myeloma protein. This is obviously only applicable to IgG kappa patients. So if it's an IgA lambda, we know that if it's an IgG kappa being picked up, it's coming from the exogenous antibody. But one strategy that DARA has developed is a DARA interference assay where an anti-idiotype antibody is added to the sample that is sent to the central lab, and then that moves DARA out of the way so you can see, is there any endogenous myeloma protein left? That hasn't yet been done with all the antibodies, but it is important for community doctors to be aware of, because perhaps somebody who is in CR is going to be called not in a CR, and it may just be a low-level interference. And the other final important thing to think about for DARA-VD is both for proteasome inhibitors and for DARA, acyclovir or valacyclovir for shingles prophylaxis is recommended. That's been known that proteasome inhibitors can reactivate shingles in 20% of patients, and the shingles vaccine, which is a live vaccine, is not yet recommended for heme malignancy. Therefore, prophylaxis is the way to go. And it's also important to remember that these are renally cleared, so the dosing of those meds needs to be adjusted for renal dysfunction. So this is a patient who was diagnosed with symptomatic myeloma, got RVD induction, transplant, and len maintenance. And fortunately, in spite of having a high-risk translocation 14-16, her remission lasted 5 years. And luckily, we have so many options to choose from at the time of relapse. Really, there's not one right answer, but the DARA-VD would be a great option and likely would give her a long remission duration.